Um, Good evening, all. Myself, Professor Dr. Ajith Pillai. I am head of the Department of Cardiology at Kaveri Hospital, Kovilambakkam, Chennai. So today we'll be discussing about one important cardiac investigations, which is coronary angiography. So before that, I welcome all the viewers to this broadcast, and I ask you to post your doubts and questions so that we can have a good interaction at the end of my talk. So I'll be talking briefly about 15 to 20 minutes. This talk is predominantly on the procedure of coronary angiography. Know about the coronary angiography. So coronary means heart or something which is related to the heart. Angiogram means something related to the vessels, blood vessels. So coronary angiography is something like the test of coronary blood vessels or heart blood vessel, the blood vessel which supply the heart. Now, why we should know about coronary angiography? Because as you know, heart is one organ which supplies blood to entire body. And as you know, whether we sleep, whether we are awake, heart is going to pump all throughout your life. So that is something, a muscular structure, because it is very dynamic irrespective of your physical condition. It needs more blood because it need to be active, metabolically active, so that it needs blood every second, every fraction of the second. So the demands of the heart myocardium or the heart muscle is quite high. So that means the stress on the vessels which supply the blood to the heart is very high. So heart vessels are supposed to bear a lot of stress related to this increased demand. And that is why we are very much worried about the blood vessels which supply the heart. As you all know, high cholesterol, high blood pressure, high blood sugar, everything affects the blood vessels of the heart and also the heart vessels of the brain. So these are two organs which are actually predominantly affected by the disease called atherosclerosis, or which is actually the common disease which is affecting the blood vessels. So we hear news about somebody dying of heart attack, celebrities, common people, politicians, even our friends, relatives, etc. So why? Because heart attack is very common in our country, and that is because we are actually having higher prevalence of hypertension, higher prevalence of diabetes, so on and so forth. So any disease which is potentially can affect a blood vessel can predominantly affect the vessels which are supplying the heart. So that is actually the importance of heart vessels. And so the fundamental test or the gold standard test for diagnosing or to find out whether there is any block in your heart vessels is actually coronary angiography. Now let's discuss a little bit deeper into that about what is actually the coronary angiography. So coronary angiography, as I mentioned, it is basically a simple test, although an invasive test. The invasive means something you do with penetrating with a needle or taking something into the body. Okay, it is just not like a scan which you perform outside the body. So you need to go inside the body to test you the blood vessels. So it is one of the gold standard. It is actually the gold standard of understanding any disease affecting the heart vessels or coronary blood vessels. Now, when we should do this, uh, the uh, the the art and the science of coronary angiography has been in vogue for the past 50 years. So earlier days, the technology was limited to very few hospitals, very few centers, but now the test is very much available across our country and across even to small um, suburban states or suburban territories, even I would say elsewhere villages. So we have actually, so the access to this particular testing or this particular investigation or treatment is not kind of restricted by the geographic boundaries anymore. Now, when we do this, so we do this when in patients who have heart attack, who are coming to emergency with heart attacks, when we do as a procedure to find out the block in the heart vessels and with an intention to treat the block so that the patient is relieved of the block, relieved of the decreased blood flow situation, and we can actually make them survive. As you know, heart attack is a giant killer. So one is actually heart attack, acute heart attack. The another indication is actually patients who do not are sick like a acute heart attack, but still have supply demand mismatch or otherwise have chest pain. We call it as angina pectoris in our medical fraternity, but it's basically a chest pain which comes on exercise or when you do some work or when you are stressed out to do some reason. So basically the indications for angiography include: one is heart attack, second is chest pain of cardiac origin, third is sometimes many people may not really manifest chest pain, they do develop shortness of breath, especially while doing some kind of work. In addition to that, there are some situations where you do angiography to rule out any major problems, especially when you are undergoing for a major surgery, like a major transplant surgery or a major liver or stomach or brain surgery. So these are all the common indications for when we actually do the test. Sometimes patients do present with cardiac arrest. Again, we will have to, because heart attack is one of the commonest cause or disease of the coronary arteries, we call as coronary artery disease, a common cause of cardiac arrest. We will evaluate once the patient is survived of the heart attack, is resuscitated and he is revived of the heart attack or revived of the cardiac arrest situation. We'll do the coronary angiography to find out whether there is any block in the coronary vessels. Now, as I told you, this particular investigation is available now in a very widely and very easily available, accessible way of treatment. We should know the common kind of protocols or common workflow. When we started doing angiography about 30-35 years back, those days, I think the procedure was entirely a kind of an admitted procedure. That means we admit the patient and a day or 2 days before the procedure, and patient is fully evaluated with blood test, like kidney function test, like blood sugar, blood hemoglobin level. And of course, because it is an invasive test, as I told you, we are entering the body, we test common viral markers, whether you are hepatitis B positive, whether accidentally you have contacted hepatitis C infection, or even very rarely we find sometimes you are due to an accidental blood prick or blood transfusion, you contacted a retrovirus infection, etc. So basically we do some virus serology also, and we used to do this as a very elective procedure on a previously admitted patient. And the test also protocols used to be longer, used to take an hour. So this was the situation I was telling about 25-30 years back. But now it has entirely become a daycare procedure, unless the patient is very sick due to heart failure or acute heart attack where the patient is already admitted. Otherwise, to diagnose a block in the coronary vessels or to diagnose coronary artery disease, the test is predominantly a daycare procedure. That is, you walk into the hospital, you stay a couple of hours in the hospital, and you go back. Just like you go and consult a dentist for do a root canal or a tooth extraction, where you stay a couple of hours in the dentist clinic and go. So the protocol has completely evolved over time. The safety of the procedure has become significantly improved. The complications have significantly reduced. So it has become a very widely available test, a very simple test in a major hospital like ours. So what we do normally is actually we see the patient a day or 2 days before the procedure in the OPD. We'll advise to do some blood tests as I mentioned. We do a basic scan of the heart to understand the heart pumping function. We do the ECG. This is actually the preliminary investigation of the patient. And then we'll ask the patient to come as a daycare procedure. On the day of procedure, patient can have light breakfast or light soft drink. They need to be about 2 to 3 hours of fasting. So that is also something which has become more kind of more what do you say, very narrowed. That means the duration in which you'll be starving for the procedure. Earlier it was whole night, but now it is only 2 to 3 hours, because we have now trials or studies which show that for cardiac procedures just 3 hours of fasting is more than enough. So patients, we are instructed to come with 2-3 hours of fasting. Usually the procedure is done through a artery in the hand. We call it as radial artery. Most of our friends would know that. Sometimes we do through the leg artery. Irrespective of whichever artery you take, the procedure should take about 10 to 15 minutes. So that is the procedure time. It will be about 10 to 15 minutes. So the doctor actually takes a very small profile needle, very small needle, punctures the artery, through which he is actually passing a tube, through which actually he'll be actually entering the heart. So this procedure, heart, as you know, has three blood vessels, two on the left and one on the right. So the operator or the doctor, we call it as interventional cardiologist. The cardiologist who performs angiography is known as an interventional cardiologist or invasive or interventional angiologist. So he takes a catheter or tube which is going to the heart, and he will inject 5 cc of contrast. Contrast is actually an iodinated contrast. So this is injected into the coronary artery, both on the left and right sides, under an X-ray machine. So this procedure is done in a cath lab. Cath lab is basically nothing but an X-ray unit which is used by the cardiologist to perform diagnosis as well as intervention testing for the patients. So patients walk in because this is a sterile environment. Patient have to accept the sterile protocols. They walk in, change to the patient's scrubs, and then go in to the cath lab, where after applying local anesthesia in the radial artery or in the groin where the leg vessel is accessed, either of them, as per the individual patient's anatomy and morphology and clinical reasons, there will be a local anesthesia. That means just to make this area numb so that the pain of needle prick is not felt. And after that, we will enter the artery. And as I mentioned earlier, we'll take the catheter through that. So the patient will be fully conscious. So this is a procedure which is completely under local anesthesia. So patient is fully conscious. He himself will get the awareness that something is passed through this hand. So through the hand, it goes all the way to the chest, and then we'll take the catheter down into the heart, which is actually in the chest. So, and then as I mentioned, we'll take angiography of the both left as well as the right coronary arteries. And these images will be processed by the X-ray processing unit and will be readily available for the doctor to see. The procedure should take about 10 to 15 minutes. After the procedure is over, the catheter is withdrawn from the body, and this needle site is actually compressed by a band or by a adhesive dressing, so that the point which is actually entered, which is about 1.5 millimeter. Please mind it, it is 1.5 millimeter hole. So an extremely micro keyhole procedure this is. And after that, we will just do a kind of an adhesive plaster here so that the bleeding gets stopped. So when you compress the artery for a few minutes, like say 5 to 10 minutes, the bleeding usually stops. That is why. Now, during the procedure, as I told you, while taking the catheter, before that, we'll give a small anticoagulation, which is called as heparin. This is basically to prevent clots which are happening with the long tube or catheter we take it. So this medicine will be acting in the body for 4 to 5 hours. Now, so this is what is a procedure is known as. So the once the X-ray images are seen, the operator or the cardiologist will see whether there is any block in the vessels. If there is a block in the vessels, he has to decide whether we need to place a stent to remove the block, depending on the clinical situation. Sometimes the block may be very minor. Anything which is more than 70% block, we consider as a significant and which can potentially cause symptoms. So we will undergo stenting. Suppose the patient is having multiple blocks, which may require 4, 5, or 6 stents, which are at multiple locations, both on the right and left. We may even consider a coronary open heart surgery, like a coronary bypass surgery. So this is basically the nutshell of the procedure per se. Now, what are the precautions you need to take? So as I told you, it is an iodinated contrast. So we always check whether the patient is allergic to iodine. Nowadays, the contrast agents which we use for angiography are extremely refined, meaning the risk of severe allergy is extremely rare, like 1 in 1 million. So that is something which you always look at. So once we do the adhesive plastic come out of the patient, we still observe the patient for an hour to see whether there is any allergic reaction to the contrast coming. Sometimes, very rarely, patients who have very critical blocks, like as I mentioned, multiple blocks, sometimes during the angiography or after the angiography, it is very common to have some mild chest pain. And it usually settles down with some medicines or reassurance. So in those patients who develop some mild chest pain, we'll take an ECG after the procedure, make sure that everything is fine. So this is what is actually the coronary angiography in the summary. So with regard to the interpretation of the coronary artery, as I told you, it is about 70% stenosis we cut it as a cutoff. So we just see there are some patients who may have very mild blocks, like 20% or 30%. So these patients are actually essentially managed with medicines. Sometimes we are in a dilemma whether the block is 50% or 70% is like that. In that case, we need to do some other additional test, like physiology test. We take the pressure gradient before the block and after the block and identify whether the block is really significant. So this is in addition to angiography. Sometimes we do something like a fraction flow reserve or FFR or physiology assessment. Sometimes we, rather than doing, not only that we do image the arteries by injecting contrast, through the contrast, through the vessel, we pass a intra-arterial scan like an intravascular ultrasound or intravascular optical coherence tomography to identify more detailing of these blocks, whether it is due to a calcium or whether it is due to a cholesterol deposition. All these things we'll check so that we know we get to understand how this block is formed and how much is a block. These are very exceptional situations where we perform this in addition to coronary angiography. Now, there are certain patients who are actually having other issues like kidney failure. This contrast is actually excreted by the kidneys. So patients who have deprived renal function, we need to be extremely careful. So first what we do is actually we will take more renal safe contrast. There are some contrast agents which are extremely safe to the kidney. Second thing is actually we limit the amount of contrast we use. We call it as ultra low contrast coronary angiography. So with very minimal contrast, with ultra modern X-ray equipment, we can get all the useful information. And as I mentioned, some ultrasound also, intravascular ultrasound also helps to limit the amount of contrast we use. Now, this is actually the summary of the procedure. Now, let's discuss about the potential risk and complication. Some of them I already mentioned. One is allergy, which is very rare now. Sometimes angiography itself can cause some pain. So that we have to see and address. Very rarely angiography, the catheter which you are passing through the artery, very rarely can cause some vessel injury here or in the groin, or sometimes in the injury into the heart vessel and all. These are extremely rare, but those requires a treatment then and there itself. And most of the time, the cardiologist is very well aware of it, and he or she can actually fix those complication on at the time itself. These are extremely rare, so I don't think there is any point in discussing it in this session. Now coming to the recovery of the patient after the angiography. So usually, as I mentioned, about 2 hours the patient will stay in the hospital, and during that time we will ask them to take some oral fluids. If they are fasting, we'll ask them to take breakfast. If they are coming during the lunchtime, after taking the breakfast, we'll ask them to have some light food, and after 2 hours we'll send the patient. The only thing which is probably going to be there for the patient is actually an adhesive plastering, which generally can be removed after 6 to 8 hours. The patient at home, he himself can just remove it. It's just like a band-aid which is staying here on the wrist. Now, it is quite common that on the day of the procedure, because patient is already traveling to the hospital, there's not an anxiety on the patient side, whether I will have some blocks or what are the procedures. So on the day of procedure, for any kind of procedure, whether it's a CT scan or ultrasound scan or coronary scan or coronary angiography, usually, even if it is not a major test, usually we find patients are quite nervous. So because of the nervous, they will be having a lot of like atypical symptoms. I would say, like for example, they would say very fatigued, very tired. So most of them get relieved after the angiography, saying that okay, this is this much. So this is something which is quite common. Sometimes, very rarely, patients can have nausea, vomiting, that may require some. So usually this happens about within 2 hours of the procedure. That's why patient usually stays for a couple of hours. We call it as actually the coronary angiography launch. The patient will sit in the, so there's no need to even lie down. They just sit in the sofa, and after that, I think they leave the hospital. And and then depending on the angiographic findings, the medicines also are modified. Suppose the patient is already on a medicine for heart attack, we do angiography, and then we find that angiogram is normal, then we can actually scale down on the medicines. That is very important. Sometimes, if the patient has got some block and patient is planned for angioplasty or stenting, we will advise add a group of medicines which are actually preparing the patient for subsequent procedure. So the subsequent procedure, angioplasty stenting, is the same protocol, same arterial access mostly, and the patient will undergo the procedure. Because the patients are implanted stents, there are situations where even with the stents, we send the patient on the same day. So even angioplasty or stenting can be done on a daycare basis. I'm telling about a situation where the patient has got a critical block. Now, there are very rare situations where the patients are complicated patients, like patients, as I told you in the beginning of this lecture, patients who come with cardiac arrest. So these are not patients who can just walk away. No, they are very sick patients. Patients who are having heart failure, as I mentioned, patients who are doing this as a preparatory or pre-evaluation checkup for any major visceral surgery. So those are patients definitely are going to stay in the hospital till their definitive treatment is carried out. So this is what is actually the common recovery. Very rarely patients do come back with some swelling here and the access site, some redness. So this requires some topical ointments or something, and then usually settles down. So it is, to sum it up, coronary angiography is a gold standard test for understanding and evaluating whether there is any block in your heart vessels, or we call it as coronary artery disease. The workflow has been significantly simplified over the past couple of decades. 99% of the procedures have become day care. It takes about 10 minutes for the procedure. And for the whole procedure to come in, patient coming into the hospital and going back, it hardly takes 2 to 2.5 hours. So extremely a safe test in a safe cardiologist's hand. It helps you to identify life-threatening problems like a critical block in the coronary artery much earlier, so that actually we can actually treat these blocks much earlier before it become very life-threatening, and pushing the heart into major crises like major arrhythmias, major heart attacks, and heart failure. So this is what I would like to sum it up today, and I'd be more than happy to take questions from your side. So please, if there is any questions, I'd be more than happy to answer. So I'm just seeing a question which is uh, um, being asked. Ajay is asking about at what age can one go through the surgery. So there is no specific age cutoff for this. So to put it to an example, we have even children who come with some by birth they will have some disease of the coronary arteries. So they will have abnormal origin or abnormal insertion of the vessels. So even we do this test even in newborns. Yeah. With regard to the upper age limit, we even do it in nonagenarians, that is even patients who are in 90s. Because as I told you, this is something which is decided by the presence of a symptom, presence of a heart symptom. So they would already have some cardiac problem. That is why the doctor is doing the test. So age is not a criteria for doing or not doing. It is basically a test to diagnose a life-threatening issue. Diagnose. So there we don't really decide on an age. It's just like taking an X-ray of the heart. So you don't say that okay because young or old we restrict it. That is for angiography. With regard to surgery, we don't generally call it as a surgery because it's a very minimally keyhole procedure. But if you're referring to the context of a major cardiac bypass surgery, yes, definitely I think patients who are very old, like 80 years or 85 years, generally if they found to have multiple blocks, we try to address through the minimally invasive like angioplasty or stenting, because bypass is an open heart surgery. Even though there are a lot of iterations have happened, like now we have even robotic or minimally access surgeries, but by and large, somebody who's above 80 or more, most of them undergo treatment with angioplasty and stenting. Very rarely we go for a heart surgery, and because of the age, they will have a lot of frailty and a lot of other comorbidity, physical disability, inability to walk, osteoarthritis, vision will be poor, hearing will be poor, overall wound healing process will be delayed because of the age. So all those patients we preferably treat with them with angioplasty. I hope I answered that question. Mr. Neville is asking if blockades are detected in the test result, what percentage of blockades is curable with lifestyle improvement and medicines, and what percentage is taken to surgery? Now, as I mentioned, generally we could take it as 70 percentage. So if you ask me why this magic number of 70, and that is being actually shown by large randomized trials which are involving lakhs of patients, like somebody who's having 70% stenosis, somebody who's having 40% stenosis. We follow them up for 10 years or 15 years or 20 years. We find that the 70% patient block patients will have more problems, more issues of chest pain, breathlessness, all those issues. So basically, as a common parlance, we understand that 70% is actually the cutoff where we say that okay, no, medicines alone may not work. We may have to treat with the more kind of interventional procedures like angioplasty or stenting. With regard to what percentage of block is curable with the lifestyle improvement should happen in all percentage of blocks, because whether you undergo a bypass surgery or stenting, if you find that let's say you are a diabetic, then you have a responsibility to control the blood sugar, and that cannot happen only with medicines. You need to cut down on the sugar, cut down on your calories, etc., etc. Suppose you are having hypertension, of course, in addition to treating the heart block, you need to control your blood pressure. How do you control? Reducing the salt intake, proper taking anti BP medicines, reducing the salt intake in your diet, take proper exercise, etc., etc. Similarly, so this is actually control of risk factors. For heart per se, we'll advise not to take a lot of saturated fat like animal fat, We'll take ask you to take a lot of fruits and vegetables, avoid high cholesterol in the diet. If someone is habituated with smoking or rejuvenating drugs, we'll strongly discourage them. If someone is very much sedentary, we'll ask them to start exercise protocols, so on and so forth. So to summarize, there is no specific cutoff for lifestyle management. Lifestyle management is good for even people who do not have any heart problem, because that will prevent the occurrence of heart problems. I hope that answers the question. Well, Manisha Jetli, she's asking how can we prevent heart attack or heart disease or stroke? What major factors contribute to heart attack? Some of them I've already mentioned, Manisha, that risk factors like diabetes, like high blood pressure, habits like smoking. These are some of the factors which we can actually modify to a certain extent. There are certain risk factors like positive family history. Sometimes we see young people coming in with heart attack. They'll have a lot of family members who are having the same problem. So these are probably genetic or related to your genes. So here we cannot change the genes we have. So we will strongly advise to be over kind of sensitive to the lifestyle habits, like very strict diet protocols, very strict exercise protocols, very aggressive control of the cholesterol with medicines. And if you are two or more family members, first degree relatives are having heart problem, then your chances of getting a heart problem is quite high compared to a general population. So here we constantly surveil the patient. In addition to say low salt, low cholesterol, low carbohydrate, high fiber diet, lowering your blood pressure with lot of water intake, low salt intake. If you're diabetic, control the diabetes. And if you're sedentary lifestyle, start some kind of workout when you are routine protocols. I mean routine lifestyle workflow, etc., etc. So this is something we advise generally patients who are coming so-called preventive heart checkups. So what you are referring to is actually somebody who is just walking in, or who is suspecting, okay, I may have some problems because someone else in my family or one of my friends had a problem. Let me check whether I am having some heart issues. So these are individuals who do not have any heart disease in the past, who never had diagnosed to have any heart disease. So we call it as preventive heart checkups. So this is also a good thing once in a year in a patient who are very high risk, like your families of diabetes, your families of hypertension, then or you are hypertension or diabetic, or you are high cholesterol. These are groups we know. Some families are like that. So if you're one of your parents or one of your siblings are having a cardiac event or very strong families of diabetes, then it is better that annually once in 12 months you undergo for a preventive heart checkups. So this is one thing which is very much available in most of the metros. Even actually in BTIR and CSAT is when we go for conference, we find that the idea of these preventive heart checkups are actually coming up in a big way. Plus social media, increase awareness among the population, overall increase in the education level. To cite an example, the smoking prevalence has significantly come down in our population. That's because of the high tax imposed on the cigarettes, and generally on the public awareness has improved. But the same can't be said for alcohol, but smoking is significantly reduced. So that is one good thing about the social awareness. So to sum it up, I think one is actually from the doctor side, we would surveil you that, for example, if you're having any risk factors, we'll ask you to come every year and to have a check for your heart so that you're developing any problem. And if you're already having some risk factors like diabetes, hypertension, we'll ask you to have a tighter control on this. So these are some of the established ways of controlling the risk factors. And suppose you are stressed also, we'll ask you to just control the stress by meditation or yoga, or changing your approach to a stressful situation. Mr. Vishal is asking about what are the risks of angioplasty and stenting? Is there any alternative other than operation? Well, Vishal, see, angioplasty and stenting, the risk factors are like one is actually the we are actually in angioplasty. Actually, we are putting a metal or a stent. These are actually very sophisticated piece of metals, which like you put lenses in your eye for cataract, or you put implants in your hip for a fracture or degenerated hip. These are products that are extremely sophisticated products, which are actually tested in animals and then human beings in lakhs and lakhs of population. Then only we are coming into the clinical practice. So, but since even then, even after this thing, maybe 1 in 1 lakh or one in a few lakhs can have the stent related complications, which is basically a clot in the stent. So that can actually cause again chest pain, block, etc. The another problem is actually the cholesterol what is getting deposited to cause the stroke, or sorry, cause the heart attack or the heart block, can again get accumulated in the stent. So we call it a stent reblock or stent restenosis. This can happen in about 1 to 2% of patients. So this is another thing. So how to prevent it? Again, like I was answering to Manisha, that you need to control whether you do angioplasty or stenting. You need to take your medicines properly. You need to take your lifestyle changes, high BP control, sugar control, etc., etc. Now, acute complications like during procedure something happens. That is something like a like for example during stenting there can be an injury to the blood vessel, so that can cause hemodynamic issues. Sometimes there can be clot which can form during the procedure. Sometimes, as I mentioned, the contrast which we use can cause some allergic reactions. The contrasts are excreted through kidney. Sometimes contrast can cause some kidney issues, especially people who are already having some kidney problems. So these are some of the complications of the procedure. Any alternative? Yeah, alternative is one is bypass surgery, as I told you. But angioplasty is now matured, so that now we know that which patient has to undergo an angioplasty and which patient undergoes a cardiac surgery. Alternative therapies are available, but they are not scientifically proven, like chelation therapy, like ECP, etc. So to summarize, if somebody is having a critical block, I think we will advise, because the risk versus benefit, any procedure we'll take. Any procedure we take in clinical medicine, we always compare risk versus benefits, and benefits are more than the risk. Yeah, I think that would be the answer to the question. Ms. Bintu Anand is asking, are there any alternative tests to angiography for patients who do not want to have an invasive test? There are some alternatives like stress scan. You can undergo a cardiac MRI. You can do a cardiac CT. But cardiac CT, again, you need to give contrast. So rather than pricking the artery here, you need to prick the vein. So technically, it is an invasive test. The problem with the invasive test is they may be sensitive, but their specificity is low. So let's say if you are going for a cardiac MRI or a cardiac CT, they say, okay, there is a 90% block. So to prove it again, we have to do an angiography. So as a screening test, some of these tests can be used. So even a treadmill test, very physiological test, you are asked to walk on a treadmill with the ECG monitoring for about 10-15 minutes. You'll be running on that. If that is showing some changes, then that shows that probably you are having some block. So these are all indirect evaluation. I told you that the gold standard is actually this coronary angiography. So if you want to confirm that you have a problem in the coronary vessel in terms of a block, you need to have an angiography. There are, of course, many screening tests which, if shown positive, then angiography can be taken as a second level test to prove or disprove whether the findings are correct or not. Yeah, that would be the answer. Pallavi is asking, is a second coronary angiography as risk as the first one? Second angiography, Pallavi, this is again, it is not as risky. It is not less risky, not more risky. It is the same procedure. So it would be done on a different indication. For example, you are undergone an angiography this year. It is shown to be normal, but you develop a chest pain 2 years later, and you undergo a coronary angiography again. So that is another indication for that. So risk, as I told you, the current workflow, I would say anything put together, whether you are having any bleeding issues, like I told you, sometimes if the bandage comes off, you get some bleeding, some allergy, all things are actually, I would say, 1 in 500 or 1 in 600, everything put together. So the procedure has become very safe, Pallavi. So I don't think that there are some substrates, like for example, patients who are having severe kidney problem, patient who are having severe heart failure, heart pumping is extremely low, These are basically sick patients, and for them even removing a teeth is risky. So it's basically substrate specific or patient specific risk only. Angiography per se is not adding any high risk. It's the purpose of this lecture is actually to just remove this idea among the viewers that angiography it's a kind of a risky test. It is not. It may used to be risky 20 years back or 15 years back, but the current workflow, angiography, I would say it's the easiest test to understand whether there is any block in the heart, especially when the doctor finds that there is a very high degree, very high chance that you may have a problem. So risk for a second or even a third angiography is same as the first one. Mr. Rohit is asking how long is angiography valid? It's a little difficult question. Early days we used to say that 90 days, but this is very arbitrary. So it is just like you are testing your vision today. You have some problem in the vision, you test, ophthalmologist or eyes optometrist is telling your power is fine, you go carry on. After a month, you again find that your vision is again having problem. Then they again test and then find that no, there is some 0.25 difference is that you can better wear a glass. They just like the issue is very dynamic. So it is not something like today you take an ECG, but as of now it is fine. The one good thing is actually if it is normal, let's say if it is normal, then it is very highly unlikely that you may require a subsequent angiography in the near future. But if you find that there is something, some abnormalities there, you have a block here and there are multiple blocks, then probably you'll be advised to undergo, you will be basically advised not to sit on the problem. You'll be advised to undergo a subsequent investigation or subsequent procedure to remove this. So yeah, we can't have a scientific answer to the question, but generally we take it a 1 to 3 months is an arbitrary period, but then it can vary, Rohit, from patient to patient. It can vary. Somebody who's having normal, I would say it stays valid for a year, but somebody who's having abnormal coronaries, then probably no. We can't say a specific interval in which we can say that it can be valid scientifically. I think that will be the probably the last question I have received. So I think I wish to thank all of you who have joined in. This lecture will be available as a recording as well. So those who have missed can also watch this. So we'll be having such lectures in the future as well, so that we are committed to the public education. So thank you for all who have joined in, and I wish to thank my team who have actually helped me in airing this broadcast. So thank you all, and I wish to log out from now. Thank you so much.